Hello, everyone. Welcome to Concord Biotech's webinar on the prevalence of invasive fungal infection. Invasive fungal infections are a significant health problem in immunocompromised patients. These infections continue to take a toll on human health and are a reason for excess morbidity and mortality. The clinical manifestations vary and can range from an allergic disease to an active infection. Therefore, there is a need for prompt diagnosis and specialist consultation. Today, we have Dr. Yash Javeri with us, who is currently associated with the Regency Super Speciality Hospital, Lucknow, as the head of critical care, anesthesia, and emergency medicine. He is the convener of the Indian Sepsis Forum and vice president of the Society of Neurocritical Care in India. He is also a medical task force member of the Confederation of Indian Industry. He brings with him years of experience and excellence in critical care practice. His special interests include sepsis, trauma critical care, ethics, critical care in resource-limited settings, and safety in ICU. He has been a keen researcher and has been on the editorial board of many journals in critical care medicine, anesthesiology, infectious diseases, and emergency medicine. Welcome, Doctor. We are immensely privileged to have you on this webinar.
Thank you. It's a privilege being on this show. Thanks, Concord and the technical team for having me here. We will be discussing in detail about invasive fungal infections as it applies to our context, the data from India and the world, and what are the therapeutic options with us as of today.
Right. So, Doctor, can you tell us a little bit more about fungal infection and its prevalence in India?
Yes, please. The data is very scant worldwide. Some of the regions of the world, particularly Northern America and Europe, they have strong data. India, the data is emerging every day. But most of the data which we have is from Northern America, Europe, and there is good reliable data from tertiary healthcare centers in India as well. So the fungal infections kill more than 1.5 million and affect over 1 billion people worldwide. The global estimates are as follows. 3,000 cases of chronic pulmonary aspergillosis, 750,000 cases of invasive candidiasis every year, and about 1,000 cases of invasive aspergillosis every year. This is increasing. There are non-albicans species which are resistant to fluconazole. That's a concern worldwide, especially in tertiary healthcare centers. This is the tip of the iceberg, what data we talk about. We have a large chunk of unforeseen disease. Lot of it goes undiagnosed because of technical difficulties, lack of mycology colleagues worldwide. So the data is scant and it's probably not representative. Especially in India, we are at a higher risk of invasive fungal infections. There is overuse of antibiotics, antimicrobials, climatic conditions are so. We are in a tropical area. Diagnostic modalities are few and scant, and the data is still emerging from various parts of the country. Least to say, we are the diabetes capital of the world. We are the HIV capital of the world. Same applies to invasive fungal infection. We are fast emerged as the world capital for invasive fungal infections. We have huge number of cases before COVID and during COVID also. Systemic steroids, immunosuppression, multiple transplant centers, these all have contributed to increasing incidence of invasive fungal infections in India. There are some data about the prevalence of mucormycosis. The computational data reveals 0.14 per thousand cases in India, whereas antifungal responsive chronic and allergic aspergillosis, the data is unknown, but it is likely to exceed 860,000 patients in India. So yes, the numbers are big and mind-boggling in India.
Well, that seems to be a huge problem. And How real how real is this problem of fungal infection in the ICU? Can you share some information about that as well?
The initial myth was fungal infections do not happen. This was the general perception amongst the intensivists about 15 to 20 years back. But as the science advanced, our microbiology and mycology services improved. They were forthcoming. We had good diagnostic acumen now with us, at least in the tertiary healthcare centers. And there is a lot of awareness amongst physicians and intensivists who are caring for such patients. Now, we are looking at the problem probably in the real numbers. The rate of incidence is comparable. In fact, we are seeing a higher prevalence compared to Western ICUs. The infection is happening in lesser critically ill patients. The fungal infection is happening earlier in the course of ICU illness as compared to West. The mean age in which this invasive fungal infections is happening in India is less as compared to West. We are seeing increasing trends of fungal sepsis in comparison to West. The mortality and morbidity is obviously high because there is difficulty in diagnosis, delay in diagnosis, and delay in initiation of the correct therapy. COVID has added another risk factor, immunosuppression. It might be because of the viral illness, it might be because of the steroids or other therapies which we are using for COVID. So we are seeing a lot of fungal infections in ICU. Non-albicans candida is increasing. Mucormycosis we have been seeing scantily in this part of the world. Aspergillus is also not uncommon in this part of the world. Yeah.
Right. So, what are the major types of invasive fungal infections that are found in India, and which are the patients who are at risk from IFI, doctor?
Yeah. Thank you. The main fungal pathogens which we see, especially in acute care and critical care, are candida. Various candidal infections are common. It could be candida bloodstream infections, it could be hepatosplenic candidiasis, it could be infiltration of soft tissue infections or joint infections. Cryptococcal, especially cryptococcal meningitis, aspergillus, chronic aspergillosis, aspergilloma, mucormycetes is also not rare in this part of the world. There are various risk factors. Immunosuppression is the most relevant risk factor, but many of these infections are found in non-immunocompromised hosts also. In recent years, fungi have been flourishing in immunocompromised patients of tertiary care centers where immunosuppression has been induced in transplant cases, oncology patients who have been immunosuppressed, chronically, critically ill patients who have been immunosuppressed, patients on high dose of steroids like COPD patients. These are all high risk patients. Patients with invasive devices, patients who have undergone genitourinary or GI surgeries, burns, these are all risk factors for invasive fungal infections. Now, if we talk about solid organ or bone marrow transplant, the risk is more for aspergillosis as compared to medical ICU or surgical ICU patients where candidiasis is common. Though this is the general trend, but this is not inscribed in stone. So we see a lot of overlap. And if we talk about oncology population where both barrier immunity and cellular immunity are compromised, we see a mix of candidiasis and aspergillosis. Same applies to COVID. We see candidiasis, especially non-albicans species. We see a significant proportion of aspergillosis. We are also seeing a lot of number of mucormycosis in COVID patients. In recent years, newer species of Candida have been emerging. Non-albicans was a majority of species of Candida. The numbers of albicans have been decreasing and non-albicans has taken over the Candida albicans infections. Cryptococcuses, there have been some new emerging fungal infections like Proicosporon, which is common in India. Out of 300 Candida species, about 31 species are found in India, which causes diseases in humans. So patients who have been in and out of the hospitals, patients who have been immunocompromised for whatever cause, and patients with uncontrolled diabetes. These three are the major risk factors for invasive fungal infections in ICU setting. The incidence of candidiasis in India is 1 to 12 cases per 1,000 admissions. The risk factors: ICU admission, weakened immune system, GI and genitourinary surgery, extremes of age, exposure to broad spectrum antibiotics and various immunosuppressants, the most common being steroids. Cryptococcus, there has been a huge jump in incidence over past few years. It is responsible for a significant proportion of meningitis in HIV patients, especially in the eastern part of India. Who are at risk factor for cryptococcuses? Immunocompromised patients such as HIV/AIDS, intake of immunosuppressive medication, and there is rise of cryptococcus in India with an association of pulmonary tuberculosis. Transplant patients again will we see a lot of cryptococcuses as compared to non-transplant setting. Aspergillus. Aspergillus is capable of surviving in all the diverse environmental conditions in India. Invasive aspergillosis is a leading cause of death in patients with hematological malignancies and transplant patients. ICU patients, regardless of immunosuppression, are at risk of invasive pulmonary aspergillosis. COPD steroids add to the risk, necrotizing pneumonia, immunosuppressant, transplant setting, both solid organ and hematopoietic stem cell transplant are risk factor for aspergillosis. COVID associated pulmonary aspergillosis is a new entity. There is a lot of overlap in the clinical picture as well as radiological picture, but we are seeing a lot of aspergillosis in COVID patients also. The last but not the least is mucormycosis. The prevalence rate is about 0.14 cases per thousand population. 16 to 23% of these patients are unaware of underlying diabetes and mucormycosis. And it is not very rare that they realize they are diabetic when they have been diagnosed with mucormycosis. Which patients are at risk for mucormycosis? Uncontrolled diabetes, hemosiderosis, iron therapy, organ transplant, and patients who are immunosuppressed. These are risk factors for mucormycosis. Thank you.
That's quite a bit, doctor, and it's quite revelatory. So, how different and severe is COVID associated IFI, and is there any particular condition that is remarked during recent incidences that you found?
Yeah. COVID makes the host immunosuppressed. The risk of secondary infections increases. The risk of fungal infections increases because there is immunosuppression. There are various other factors which adds to the risk. Prolonged hospital and ICU stay, invasive devices, invasive procedures, immunosuppression because of non-judicious use of steroids, tocilizumab, cytokine storm, and poor infection control practices. These all add to the risk of invasive fungal infections in COVID. Invasive fungal infections are emerging as a serious secondary infections in patients with COVID-19. There is often diagnostic dilemma, especially if we talk about pulmonary aspergillosis in COVID-19. It is difficult to suspect because there is clinical overlap, there is radiological overlap. Studies have indicated excess mortality rates in such patients. High prevalence and absence of classic host factors for invasive fungal infections make diagnosis difficult. Necrotizing pneumonia, any viral pneumonia is a risk factor for aspergillosis, so is COVID. COVID-associated pulmonary aspergillosis and mucormycosis are the two incidences most commonly seen during COVID-19. But candidal infections, especially non-albicans species, are also not rare. Candida auris has been reported, and there have been few outbreaks of Candida auris. Probably it could be attributed to poor infection control practices, and this has been trend globally. But we are seeing little more than the world is seeing in terms of invasive fungal infections in COVID-19. Yes, please.
Right. So, doctor, what is the relationship between mortality and timing of
Yeah.
antifungal treatment? I mean,
Yeah.
is there some information that you can share with us on this?
Yeah. There is delay in recognition, there is delay in suspicion, We have a longer turnaround time with the conventional mycology. Antigen test and radiological testing will help us diagnose invasive fungal infections faster, but there is often delay on part of physician in recognition and sending samples, and then added delay in the reports which tell us that this patient is probably having an invasive fungal infections. The cost is often prohibitive, so there is delay in start of antifungal treatment for various reasons what we discussed. The longer the delay, the higher the mortality. If we delay by about 12 hours, the mortality will increase by 5%. This is an average. This was published by Moral Group in 2005 in antimicrobial agents and chemotherapy. So we need to suspect early. We need to start the right antifungal therapy early. Yeah. Yes, please.
So, yeah. So, how can you tell us a little more about how you go about diagnosing kappa and mucormycosis?
Yeah. Whenever we talk about a mycological diagnosis, we need to send the right specimen, the right clinical specimen. We need to obtain a specimen from patients' lower respiratory tract, which are representative. We need to test for Aspergillus galactomannan antigen and fungal culture. Bowel fluid and lung biopsy samples are the specimen of choice. However, we understand in COVID-19 era, we try to be least invasive. Bronchoscopy is not done at times for various reasons, but if it has to be done, it should be done. These are high risk procedures, so it should be done with proper infection control measures. After obtaining the primary result, confirmatory galactomannan testing should be sought. And if your clinical suspicion is high, we have to look at serial galactomannan levels, look at the HRCT finding, look at the clinical findings, and look at the antigen test serially. And if your suspicion is high, you initiate antifungal therapy earlier than delayed. There have been various diagnostic challenges. We all understand. There is overlap, clinical as well as radiological. Especially if we talk about COVID-19, the signs and symptoms overlap. Diagnostic tools are lacking, and pulmonologists and physicians, ICU physicians are reluctant to do a invasive procedure. Often there is difficulty in identifying a specific pathogen due to histological similarities amongst various fungal pathogens. Specific signs, symptoms do not appear till the disease has progressed. So once the disease is not overt, the diagnosis is difficult. But as the disease has progressed, it becomes fulminant. The diagnosis is easy. So we lose a lot of time in in getting the right diagnostic modalities. So we should have the antigen testing as well as HRCT done earlier to diagnose invasive fungal infections early. If we talk about mucormycosis, there is no specific biomarker for mucormycosis, and hence a negative galactomannan and beta-D-glucan are useful pointers to rule out other mold infections. A histopathological diagnosis is must. Rapid diagnostic methods like biopsy, QH mount, and calcofluor stain will guide you to therapy. Biopsy remains the mainstay of diagnosis, and the benefits of procedure outweigh the risk. Even in a difficult to access location or in presence of coagulopathy also, biopsy remains the gold standard for diagnosis of mucormycosis. If we talk about candida, blood cultures, and the judicious clinical sampling wherever you think the site of infection is there is must. Thank you.
Right, doctor. So, what is the defining line of treatment, and what is the role for liposomal amphotericin B in this?
Yeah.
If you can share that, yes.
Yeah. If we talk about the most judicious therapy, it depends on the context. I cannot give you a thumb rule that this is the best therapy, that will be wrong. But most of the case scenarios, liposomal amphotericin B in serious life-threatening invasive fungal infections will remains the drug of choice. This is a drug which has withstood testimony of time. The evidence, clinical evidence is huge. The resistance among various fungal species is very, very rare. It covers wide variety of fungal infections which are seen in this part of the world. However, azoles could be the first line of treatment for non-serious invasive fungal infections, but the dividing line is very, very thin. Reports of azole resistance in kappa infection are emerging. Voriconazole initial therapy can also increase the chance of azole resistance in aspergillosis. In such cases, liposomal amphotericin B will be the treatment of choice. Investigation of liposomal amphotericin B has shown a positive correlation between in vitro susceptibility testing and positive clinical outcomes in patients with invasive aspergillosis. If we talk about the resistance patterns of antifungal therapy, this blue line is fluconazole, red line is echinocandins, and this is multi-drug resistance. If we talk about fluconazole, the sensitivity pattern has been almost same. We see 6 to 10% of resistance in various species. If we talk about echinocandins, the sensitivity was very good. The resistance was rare, less than 1%, which has grown up to 3 to 5% now. Multi-drug resistance in invasive fungal infections is still a very, very rare phenomena. This is one of the most scientific and widely published data. This is from Sir Gangaram Hospital newsletter. It's a busy slide. What I want you to focus on is this part. If we see amphotericin B and various species of fungal infection, most of the candida, except for candida auris, will score 100. Cryptococcus again 100. Trichosporon is again scoring 100. So amphotericin will show you the best result, except for candida auris or hemolinae, where the resistance to amphotericin B is known. Whereas fluconazole, you can see there are big whites, 0, 0, 0. There are at least 3, 4. Candida glabrata, obviously, it is not working. Voriconazole, Candida glabrata is a white. Auris, again, the sensitivity is very, very poor. Rugosa, again, does not have good sensitivity. And same applies to most of the echinocandins also. You can see whites at many places. So, looking at this table and the Indian context, for vast majority of seriously ill patients with invasive fungal infections, amphotericin B would be the first line. Echinocandins could be the second line if there is organ toxicity like renal dysfunction happening. So recommended initial dose, you have to use the maximum dose. It should be 3 to 5 milligram per kilogram. We generally start with 5 milligram per kilogram of liposomal amphotericin B. You should not be making any changes in the loading dose of liposomal even if there is organ dysfunction. The best choice of any antifungal for invasive fungal infections is IV because there are various issues with other preparations, especially malabsorption, especially if the patient is critically ill. Liposomal amphotericin B is an antifungal therapy for choice for all patients with mucormycosis also. Thank you.
Thank you, doctor. Now, how does liposomal amphotericin B compare with echinocandins and azoles? Is there some light that you can shed on this?
Yeah. As we discussed in previous slide, there are some voids where echinocandins do not act. So we have to avoid echinocandins in those settings. For that, we should be aware of anti-susceptibility trends for various fungal species in our ICUs. Liposomal amphotericin B versus echinocandin, you have to make the choice in the context. If there is organ dysfunction, obviously echinocandins will take over liposomal amphotericin B. Whereas if there is liver dysfunction, the choice could be liposomal, or some of the echinocandins could be safe in hepatic dysfunctions. Azoles we will try to avoid in serious life-threatening infections. However, once your patient has been stabilized, the threat from invasive fungal infections has been reduced, and you have antifungal susceptibility testing with you, you can de-escalate to an azole agent. The azoles primarily block ergastol synthesis by inhibiting lanosterol, a primary target in the fungal membrane that is not present on the host cell membrane. So this is not present in the human and mammalian cells. That is why the liposomal amphotericin B does not have the toxicity. Echinocandins have success in the clinic owing to their broad spectrum fungicidal activity, reduced drug to drug interaction, and improved safety. If we compare liposomal amphotericin and echinocandin to voriconazole, the drug to drug interactions are much less. Liver enzyme induction is much less with liposomal amphotericin as well as echinocandin. Echinocandins block 1,3 beta glucan synthase, which helps to form the cell wall, a unique structure of the fungus that is not present in the mammals. The IDSA guidelines recommend lipid formulation of amphotericin B for treatment of various IFIs. IV amphotericin B, a polyene, binds to aldosterol in the fungal membrane, forming pores and leading to cell death. It also has some oxidative injury to the fungal cell, killing the fungal cell. Also, there are some immunomodulatory properties of amphotericin B. It is used to treat a wide variety of fungal infections. It almost covers the whole spectrum of fungal infections. I will reiterate it again. It covers invasive aspergillosis, mucormycosis, cryptococcal meningitis, and vast majority of invasive candidiasis. The lipid-based formulations are preferred for critically ill patients who might have underlying renal dysfunction, patients who are on therapies which can compromise renal function, and organ transplant patients, especially renal transplant patients, where already the renal functions could be compromised. There are three lipid preparations of amphotericin B which are available to us. Amphotericin B lipid complex, which is called ABLC, amphotericin B colloid dispersion, ABCD, and liposomal amphotericin B, which is LAMB. There are various pharmacokinetic and pharmacodynamic advantages with each of these agents. This is by virtue of concentration of amphotericin B as well as the peculiar preparation of each of this lipid formulation of amphotericin B. So if we talk about systemic antifungal agents for various candidiasis, as we already discussed, amphotericin B, most of the candida species are covered. Fluconazole, you can see avoid in cruzi. Glabrata will show variable sensitivity. Itraconazole, glabrata is again showing poor results. Voriconazole again poor. Posaconazole again poor. Echinocandins cover most of the candida. Flucytosine, fungal genera in which resistance is possible. Now, if we talk about modes which are not rare in this part of the world, amphotericin B will cover fumigators, but Tadius and Pseudosporium could be an issue. Fusarium resistance is possible, so you have to look at your antifungal susceptibility data. Zygomycetes, again, it is covered well with amphotericin B preparation. Fluconazole does not cover all this. Itraconazole, again, you can see much void here. Same applies to voriconazole. If we talk about echinocandins, you can see almost half of the mold infections are not covered. And the notable being zygomycetes, which is responsible for many of the mucormycosis cases in this part of the world. 5-FC, again, a poor agent for most of these infections. Necessity is the mother of infection. This is a silly proverb. Necessity is the mother of futile dodges. It is much closer to the truth. The basis of growth of modern invention is science, and science is almost wholly the outgrowth of pleasurable intellectual curiosity. This applies very much to amphotericin B. The conventional amphotericin B has its side effects, but science and clinical evidence help us to decrease the side effects. We improvise on the preparations, and this is the hard work of last 50 years. Now we have 4 preparations, and we are trying to decrease the side effects with each preparation of amphotericin B. The true preparation, the true lipid preparation of amphotericin B is the liposomal amphotericin B, and there are various preparations of amphotericin B based on lipid which are available today. These vary in respect of lipid configuration. If we talk about liposomal, these are like SUVs, single unit vesicles. The molecular concentration of amphotericin is about 10%. Diameter is 0.08. You can see this is the smallest size. The dosage is 3 to 5 milligram per kilogram. Why is the dosage high? Because it has less molecular percentage of amphotericin B. It has more of lipid. Why there is more of lipid? To decrease the toxicity. How does it help? It increases the Cmax. More concentration is available in the blood. Area under the curve is more. So the drug is available for a longer time. The volume of distribution is decreased, which means the drug is available in the blood for a wider distribution at the site of infection. Nephrotoxicity is negligible and infusion toxicity is also mild. So we have improvised on the conventional amphotericin B, and nephrotoxicity is very, very rare with most of these preparations now. This is the hard work of various scientists and ID and clinical microbiologists in last 50 years, and we have improvised quite a bit on this preparation of amphotericin B. Antifungal prophylaxis with liposomal amphotericin B and caspofungin in high-risk patients after liver transplant. So we continue to improvise and we continue to have clinical evidence on various entities of lipid formulations and in various clinical contexts. So if we talk about liver transplant patients, patients receiving prophylaxis with liposomal amphotericin B had a reduced ICU stay and an improved Th2 status. What is this Th2 status? This is the anti-inflammatory response which is seen after a fungal infection, as well as a reduced number of post-transplant bacterial infections. Now, if we talk about persistent fever and neutropenia, this was published in NAGM. There were fewer proved breakthrough fungal infections among patients treated with liposomal preparation. With liposomal preparation, significantly fewer patients had infusion-related fever, and nephrotoxic side effects were also less frequent amongst patients treated with liposomal preparations. And this is the comparison to various drugs. What is notable here? Liposomal amphotericin B is the gold standard for comparison of various therapies. If we talk about invasive aspergillosis, and where they compared a high dose of liposomal with 3 milligram per kilogram, the 12-week survival was 72% in 3 milligram group versus 59% in 10 milligram group. More toxicity with 10 milligram per kilogram group. So the dose will be 3 to 5 milligram per kilogram. Invasive aspergillosis, conventional 1 milligram versus liposomal 5 milligram. 14 out of 32 patients complete response with liposomal, whereas 6 out of 34 had only complete response. In neutropenia, liposomal amphotericin group fared better than control where there was no prophylaxis. Persistent fever in neutropenia, where they compared deoxycholate, which is the conventional preparation with low liposomal, their survival was similar. Fewer confirmed breakthrough invasive fungal diseases in the liposomal group. Invasive candidiasis, micafungin versus liposomal preparation, fewer adverse events in micafungin. 89.6% micafungin and 89.5% had survival with liposomal, which is almost comparable. Cryptococcal meningitis, overall mortality at 10 weeks, 11.6%, no significant difference between groups of conventional, liposomal, low dose, and high dose. Visceral leishmaniasis, all combination liposomal groups non-inferior to standard 30-day deoxycholate amphotericin B therapy. So the clinical evidence is huge and varied, and we are trying to gather more and more clinical evidence to make it a safer therapy for patients. Thank you.
Right. Doctor, can you share some case studies with us on this in your learnings?
Remains COVID, sadly, and we are still living with COVID. We had few case reports of COVID. I will share the notable amongst them. The first case is a 70-year-old female patient with heart failure and CKD on hemodialysis 10 days post-COVID. She was admitted under cardiology in CCU. The outcome, which was anticipated, was poor. There was orbital and maxillary swelling, dental ophthalmic, and a delayed ENT reference was taken. And you can see the sinus opacification. This is very, very typical for mucormycosis. And there was palatal eschar. Palatal eschar is almost diagnostic of mucormycosis. You can see this blackish discoloration in the palate. So the clinical suspicion was high. The patient was initiated with liposomal amphotericin B, 5 milligram per kilogram, and we had a favorable outcome in this patient. So this you can see the sinus endoscopic biopsy was taken, microbiology, the GMC stain was showing the typical pictures, and acute angle staining was also done. Another case, a female patient, known case of diabetes, under a neurologist for acute vascular headache. HbA1c was 11, response was good. Discharge and had recurrence of symptoms 10 days post discharge. ENT referral was done and endoscopy was performed. Biopsy and QH mount was done, and the picture was similar, suggestive of mucormycosis. In fact, diagnostic of mucormycosis, liposomal amphotericin B was initiated. Discharged uneventfully. Patient was reviewed regularly and improved clinically with healthy nasal mucosa seen on endoscopy. The treatment principles which I want to highlight in both of these cases is we have to have a high threshold for diagnosis. Choose the right surgeon or physician early. Send the mycological samples in time. Early administration of active antifungal agents. Try to reverse the underlying risk factors, uncontrolled diabetes, immunosuppression, complete and repetitive removal of all infected tissues, and at times you have to use various adjunctive therapies for a successful outcome. Liposomal amphotericin B is the drug of choice, generally 5 milligram per kilogram, but we can go up to 10 milligram per kilogram if CNS is involved. Surgery and liposomal amphotericin increases the survival rates as well as clinical cure rates. The predicament in clinical practice remains undertreatment versus excessive or irrational use of antifungal therapies. We do not want to miss on the cases. At the same time, we do not want to give a bombard of generic therapies for all the patients. So, early suspicion, early sampling, and early adequate antifungal therapy will be the way forward if you want to treat these patients. But we understand often there is diagnostic dilemma. Mycological services are not that well established in many of the hospitals. So, the essence of wisdom remains in the ability to make the right decision on the basis of inadequate evidence. For this, we have to do a lot of thought-provoking discussions and lot of cross-talks between infectious disease specialists, intensivists, ENT colleagues, and microbiologists. And with respect to fungal infections, we need to increase awareness amongst the general practitioners also. Thank you.
Doctor, that was very illuminating, and I think that is very informative. Um, Very grateful to you for sharing your learnings and sharing these findings with us. It's been a pleasure interacting with you, sir.
Thank you. The pleasure is mine, and we look forward for more such meetings. And our aim is to reduce mortality from fungal infections and to increase awareness not only amongst clinicians working in hospital, but also in the physicians who are working in the community. Thank you.